This is a personal story of a journey through the Veterans Administration from my eyes, and so you will be subjected to my views, which border on being prejudices. And I'd like to kind of keep this informal so that if you have questions at any time, please feel free to ask. And so we start. Disclaimers. I am retired from the VA and draw a pension. So I could have some bias here. I was director of the National Anesthesia Service from 94 to 98 during its birthing process. And during this time, I spent $1.2 million of your money in running the National Anesthesia Service. How many of you are familiar with the Veterans Administration? Kind of so. Okay. Is there a pointer?
No, there's not.
Okay, let's see if I can use the mouse here. Yeah, okay. Let's do this. There we go. Okay. Secretary of Veterans Affairs. He's a cabinet member. And we became a cabinet in about 89 or so, maybe 1990. And as you can see, there's quite a superstructure here to the bureaucracy, including the Inspector General. We'll be talking more about the Inspector General later. So we have all of the assistant secretaries here. They all reside in Washington, D.C. And then we come down to the three major branches of the Veterans Administration: the Veterans Benefit Administration, which has to do with pensions. It has to do with payment to disabled veterans. We have the Veterans Health Administration, which runs our hospital right down the street here. And then the National Cemetery Association, which takes care of the veterans' burials. So in terms of the budget, medical care occupies 41% of the VA budget at $54 billion. Benefits, by and large, the majority here at $70 billion. Cemeteries really quite small. And then for information technology and new construction and other miscellaneous stuff, we got about 5% of the total budget. Now, unfortunately, the Veterans Administration is part of the discretionary budget of Congress. And so the vets are always pushing for more benefits, and Congress is saying we don't have the money. And now that we're particularly in the post-Iraq situation with many veterans injured coming back with lifelong disabling injuries, including PTSD, the VA is going out for more and more money at the same time that the Republicans are advocating. Now, I'm on my podium here now, you understand. Advocating cutting unemployment insurance and cutting health and benefits and stuff like that. So there's this great tension in Congress. And by the way, I think I'm still correct in saying that we are on a continuing resolution for the current budget, that Congress has not yet gotten the work done it was supposed to have done by the 1st of October and have all of the enabling and funding legislation passed. Well, when I was working for the VA, we suffered because it means that we were always under last year's budget under the continuing resolutions. Okay, let's get to the topic in hand then, that's anesthesia. And the early years are kind of dim because nobody kept very good records that I've been able to find anyway. Many academic medical centers had contracts with the local VA. The VA paid for the contract for the academicians to come across the street and to take care of the veterans and to teach residents. Within the VA, there were some that were hired full-time, By and large, these were foreign medical graduates who were willing to accept, at that time, the very low pay scale that the VA had, and then most of the anesthesia was provided by nurse anesthetists. In the late 1880s, both the nurse anesthetist and the anesthesiologist and the contract anesthesiologist from the medical center started applying to VA central office for some form of representation so that there was a place at the table, particularly with surgery, because surgery was certainly captain of the ship back then, and anesthesia was kind of scruffing under the workload and the lack of ability to have input into their own working environment. In 1991, the VA, being very short of anesthesia people, said, we'll take our own nurses and we will train them with the stipulation that they come back and work as a nurse anesthetist for 4 years, following their, at that time, about 2 years of training. So the nurse anesthetists within the VA became fairly active. They were pushing for pay equality on the outside because the VA paid nurse anesthetists the same as a floor nurse. And yet the nurse anesthetists on the outside, because of supply and demand, were getting paid considerably more. So the VA finally recognized that they had to pay the nurse anesthetist more in order to maintain a good quality of nurse anesthetist. So in 1991, the nurse anesthetist got what was called locality pay. And this was a very interesting problem for the VA because the implementing regulation says that you will pay a beginning nurse anesthetist in the VA what a beginning nurse anesthetist makes going out into the locality. And for thus here, it was essentially Johnson, Washington, and Iowa counties. So the regulation said the VA has to go out and do a survey of starting nurse anesthetist salaries in the location. Well, here's what happened. Medicare Part B pass-through. Anybody heard of this before? Okay. Well, for small hospitals that do less than 900 cases a year, nurse anesthetists, instead of billing through Part B Medicare, get to bill the hospital, and then the hospital bills through Part A. Well, anesthesia is not paid well by Medicare. But when you pass this through the hospital and it comes out on the Part A side, which is the hospital care, there's the full payment for the services provided. Well, this was a real good thing for the hospital because they got paid full. They would take half of that, and then they would pay their nurse anesthetist much more starting salary than you would if you went out to a major hospital without Part B pass-through. And so when I was chief over at the VA, the salary of our nurse anesthetist doubled, which they were very happy about. And I went to our hospital administrator and I said, you know, I'm really bothered by this. And he says, you should not look askance at your good fortune. Okay. On the anesthesiologist side, the MD side, we started kind of getting together in the 70s, and I could find this list of presidents. And as Donna said, I was president of the Association of VA Anesthesiologists from 92 to 94. I came to the VA here in 87, and as I became very involved and engaged in VA activity because the VA believes in productivity, and they encourage productivity by offering a lot of educational services. And so as I was working up, you might say, the VA ladder, I went to leadership training school, management training school, and tried to make myself known as a presence in the VA, at least locally and in Washington, D.C., by writing letters, like to the chief surgeon here, Dr. Lefemin, kind of brash at me because I'd been a chief here for just 2 years. And I said, welcome. Well, he was a surgeon from the outside, but at least at that time, he was in charge of anesthesia because anesthesia yet had not been birthed as a specialty in VA headquarters in Washington. So just some statistics here in terms of nurse anesthetists. We're not a very big group of anesthesia within the VA, and 86 through 89, you see that the number of nurse anesthetists is going down. And for down here, the anesthesiologist, the numbers are going down. And the part-time were primarily academicians coming across the street like we did here. So the VA had really kind of a nasty problem of how are we going to provide enough anesthesia services, and of course anesthesia and surgery are linked hand in glove. We don't have anesthesia, we can't do surgery, and if we can't do surgery, we can't take care of our veterans. One of the very, very points of contention among the anesthesia people was this piece of paper we call the Anesthesia Record. It had been developed by a joint commission for federal service in 1975. And when I came on board in 87, it was already horribly obsolete. And yet the regulations were firm in that we had to use the anesthesia record. So lots of work done on trying to create a better paper anesthesia record. And under my tutelage when I was at VA headquarters in Washington, D.C., we finally got approval so that each local VA medical center could generate its own record to fit its purposes and needs. And of course, then the electronic anesthesia record was coming in 2000, and we'll talk more about that later. So we have several documents here dealing with, please, let's work on the anesthesia record. This was a letter from my colleague, McIver Edwards, who was at the VA in Philadelphia, saying, we got to do something like this. And so Howard Zotter was a past president of the American Society of Anesthesiologists, who at this time was chief of anesthesia at the Phoenix VA. So, contracts. The VA could not hire enough anesthesiologists to do the work. Didn't pay enough compared to the outside. They just didn't simply have the money, nor did they have the skills at that point to say, how much should we reimburse the people who work in our operating rooms? So several Office of the Inspector General investigations through the 90s said that the VA is paying too much. Well, this was always a contention and a lot of friction between the academic centers. So in 1992, McIver Edwards and I came up with a paradigm for saying, what's the value of an anesthesiologist working at the VA? And we took into account here clinical time, administrative time, and research time. And we said, if you'll pay us Medicare rates for anesthesia, we can make this work. Okay? It was only two things we had to choose: the value of the reimbursement and the percentage of time allocated for administration and for non-clinical time. It was rejected as being too simple. But it was highly, highly documentable because all of the data came from the VA's mainframe computer. Well, VA anesthesia was a mess in the early 90s. And this is a letter that came down from the Office of Inspector General. And I'm going to read this sentence here. The lack of written criteria on this program make it of interest for audit. Okay, now when the IG starts talking about audits, oh boy, people start to perk up. And so the audit was done in the summer and fall of 92, and I got a draft copy of the audit, as did many people in late 92, and the handwriting was on the wall. The IG wanted to split anesthesia off from surgery in headquarters in Washington, D.C. So finally, here comes the document down like a ton of bricks. We knew it was coming. We could dodge it pretty easily, but not exactly. This is dated September 29th of 94, so it took 2 additional years to get from the draft to the final. And it says here, Veterans Health Administration needs to provide more effective direction of anesthesia activities. Okay. Well, headquarters, knowing that this is coming down the line, said we need to work on this. We have obtained concurrence from VHA, that's the Veterans Health Administration Management, that we need to start an anesthesia service, and we would like your approval. So this percolates up through, and it takes a year for that letter to percolate up through. And so we get down here to now our 93 of October, and we finally have the permission to have a separate anesthesia service in Washington, D.C., signed by, at that time, Secretary of Veterans Affairs, Jesse Brown, in October of 93. So it took a year for that permission to go through this bureaucratic change. The Veterans Administration is not known for being nimble. So here was the construction as it came down from above. For the headquarters anesthesia service, there was to be a director, a deputy director who was going to be a nurse anesthetist, a field advisory committee of 4 anesthesiologists and 4 nurse anesthetists, and then some support staff to be at the headquarters of the director, who was to be a board-certified anesthesiologist. So I put in my application to become director, and it took about 9 months or so before I heard anything out of Washington. That's speedy compared to today. Anyway, Loretta Wasi, who was a very prominent nurse anesthetist in the Association of VA Nurse Anesthetists, was appointed deputy director in June of 94, and she was half-time. And I got my appointment in August of 94 at .49 headquarters and .51 here in Iowa City, and I was chief of the anesthesia service here at that time. So then we had the decentralized office outside Washington, D.C., and I picked up my 2 full-time people here, and we opened for business in February of 95. Well, we had a very long list of things to do. This is Jesse Brown. Here I am in my younger days, and this is MacIver Edwards, and Jesse Brown had to deal with 2 redheads. Okay, so we had to have a mission statement, and this actually took quite a long time to write, but consultation and guidance and policy and procedure was what we had to do. And we said also we need to have respect for the local services and sections and their needs. So our motto, an official motto, was, we're there to support the people in the trenches to do the job the best they know how to do, and then to get out of their way. Now, this was an antithetical approach to standard VA structure, and yet we enjoyed it very much. So the VA National Anesthesia Service, we had to do organization, and this is the birthing document because there was nothing in VA literature at all about anesthesia. 0. It had run amok. So we had to say, how are we going to get organized? We have the policies and procedures of the services and sections we need to do, continuous evaluation of care, TQI, QA, whatever you want to call it. We got to have some mechanism for making sure that we deliver the best care policy, and then the guidelines for continuing education. The Field Advisory Committee and the Deputy Director and I spent 6 different retreats over a year and a half writing this document. Okay? And many of you know that there has been a great deal of friction between nurse anesthesia and anesthesiologists throughout the United States. It all boils down to money. Who can make their living the best? Who's the cheapest? Best care? A huge amount of friction. And it was intensified that both of the national offices were in Park Ridge, Illinois. So this was the group that we put together. This is our field advisory committee from that time, working hard around the table to get things done. Okay. The major bone of contention was supervision. How are we going to practice anesthesia within the Veterans Administration? And we came up with this language in the draft document that said that we have a care team, nurse anesthetist and anesthesiologist. Where there's an anesthesiologist, he's boss. Where there's a nurse anesthetist, the chief of surgery is boss, captain of the ship doctrine. Okay? And, oh my gosh, you would think this is rather simple and straightforward, makes a lot of sense. Well, we sent our draft document both to offices in Park Ridge. We kind of said in the document, anesthesia is the practice of medicine. Okay? And the American Association of Nurse Anesthetists had no comment until they sent it to their lawyers. The ASA had no comment until they sent it to their lawyers. And they said, both of them in unison, we do not like this document. Oh my gosh. So, both of these national organizations contacted headquarters in Washington to stake out their positions. And, you know, this is to be just as simple. Let's just write this document and put it in effect. Away we go. And all of a sudden, Washington gets bombarded by these two rather large national organizations saying, we don't like the document. Okay, so Ken Kiser was the Undersecretary for Health at the time, and perhaps some of you have heard from his name in association with some very intense efforts in quality management. Really, really quite a good guy. So the American Society of Anesthesiologists sends a letter to Kiser saying, physician supervision, yeah, we like that a lot. And the AANA said, absolutely not, we want independent practice. And they use an example of the Navy. The Navy said, all flag officers need an anesthesiologist. Anybody under that can have a nurse anesthetist. And that was because of manpower issues, that they could not have an anesthesiologist on every battleship. So, now we have Park Ridge, both offices, writing congressmen and senators. Oh my gosh, wow. And a year later, president of the ASA, Norrig Ellison, said, Scamman, what the hell are you doing in this document? Yeah, and it was really, it just crushed me. Because we had spent a year and a half with the people in the trenches, the anesthesiologists, the nurse anesthetists doing anesthesia in the VA, and then we get these outside influences, and we really got beat up badly. It was not a pleasant time as we were trying to continue the birthing of the headquarters anesthesia service. So we have now a letter from Bill Owens, who's turned out to be a pretty good friend of mine since, that the nurse anesthetist must be supervised by an anesthesiologist. Well, it wasn't all that much later when CMS, Medicare Services, came out with a regulation saying a nurse anesthetist must be supervised by an anesthesiologist. Yay! But if your governor opts out, that requirement is removed. Okay? So perhaps you've heard of opting out in terms of coverage of nurse anesthetists. And Iowa opt out, you're the second state to opt out. Now, it's a double-edged sword, opting out. But what it meant now was that the new policy and procedure out of the VA, and this was written after I was no longer in Washington, D.C., where there is no anesthesiologist, anesthesia choice is determined by the anesthetist. This removed captain of the ship document philosophy from VA anesthesia. And this was really quite a breath of fresh air, because we have no evidence within the VA that nurse anesthesia is inferior to anesthesiologist anesthesia in any respect, even though we're dealing with some of the sickest patients around, that the outcomes in Veterans Affairs hospitals, and there are 32 VA hospitals that have no anesthesiologist, their outcomes are equally as good as the team care practice. I sent a proposal to headquarters that I study this, and they said, not on your life. We're tired of working with Park Ridge. Okay, so in the 4 years that I was director, we got the handbook written, and if you go out and do a Google on VHA 1123, you can get the entire document. We wrote a service chief's handbook for new service chiefs because there was always a great deal of turnover on them. Bulk purchasing policies, which the VA now is expert at, buying their drugs from the lowest bidder. Wouldn't it be neat if Medicare and Part D had that also? But the pharmaceutical industry lobbied so hard that that was excluded from Medicare Part D. The draft anesthesia formulary saying these are the drugs that we need in anesthesia. Pain is the fifth vital sign. The VA led the way in that, thanks to Loretta's work. Monthly conference calls for service chiefs. We had a round table, and then we put out a quarterly newsletter. So we had a pretty good just after, within the 4 years, had a good thing going. We raised it from the ground up. Well, my appointment was not renewed. And I was kind of surprised at that, but not because I was in the hot seat for a lot of those 4 years and created a lot of controversy. And you get rid of people that create waves by drowning them. Loretta's was extended for 4 more years. There was nobody that followed me for 2 years. So that director slot sat empty for 2 years in Washington, D.C. Mike Bishop, who was chief of anesthesia at the Seattle VA, finally got appointed, and he was in his office for about 10 years. And then he left the VA. It was empty again for 2 years. And then just very recently, John Sumping, who's now at the Dallas VA, was appointed as acting. He will probably get appointed the true director. But one of the nice things is that I know John very well. He was on our faculty here at Iowa for 12 years, and I had a lovely conversation with him on the phone yesterday. So, what's happening to VA anesthesia now? End-of-life care. We're now getting involved in palliative sedation. Okay, now that's a very controversial thing, but VA anesthesia is attacking it, along with VA internal medicine, VA surgery. How do you have a good death? And that's now becoming very interesting because it's a ground up from the families. I no longer want you to do everything for grandma, keep her comfortable while we gather around her bedside. And I'm totally in favor of this movement within the VA. Now, the VA, being a very large organization, had to divide itself up in districts. And here we're now involved in District 23. You notice that there is no District 13 or 14 because 13 was here and 14 was here, and they were the smallest ones, and it was just inefficient to have such small areas, and so they combined for 23. Well, this is important in terms of electronic anesthesia records, and I'll get to that in a minute. Resident education, another very important facet of the VA. Many of us got our best education at the VA. That's where we had the most autonomy. We had the sickest patients. Boy, did we learn a lot and became very skilled as physicians. Well, when I became chief over here at this VA in '87, we had 6 resident slots. And the VA said, we expect 6 residents to be there every day. What's wrong with that picture? But you cannot cover nights and weekends, with 6 people and expect 6 to be on duty in the daytime. Well, the VA said, well, nights and weekends are not reasonable. At the same time, this was in the early 90s, anesthesia became an unpopular specialty. And we really had a decrease in the resident applicants. We had the residents of the VA, professor and head at the U pulled them back. And so the VA said, well, if you're not having residents here, we can't pay for them. And so at the present time now, the VA rotation for anesthesia residents is an elective. And I'm really kind of sad at this because there's a great deal of patient care education that the vets can give to our anesthesia trainees. Our nurse anesthetist students still rotate through the VA. Pay for anesthesia personnel. When I was in the VA, we had our basic pay, physician pay, and that's what the internists and other people got. But anesthesia, being a scarce specialty, got a bonus. And that was always a bone of contention. How much should the bonus be? How do you define how many people you need to pay for? We kind of talked about that earlier, the value of an FTEE. And so now VA physicians have pay quite comparable to our College of Medicine physicians. One of the problems, though, that the VA demands documentation of its money's worth. And one of the reasons that we kind of got away from fractional physician assignments is that the VA demanded that if you have a physician working at the VA 5/8 and the rest of the times at the College of Medicine, you've got to prove by time cards that they're over there 5/8. Okay? And with rotating schedules, that became very difficult to do over every 2-week pay period to have that physician present in his boots on the facility 5/8 of the time. Just didn't work. And so us in anesthesia now, we have a contract, and I think everybody's satisfied with the contract. I have no idea the details of the contract. Okay, now getting back to the map of the 23 different areas, electronic record keepers, and this is where the VA has done exceptionally well. The VA has the finest medical record in the world, electronic medical record. It's called VISTA. You can go to any VA and pick up the medical record on any VA patient. It's all networked. Their medical record is in the cloud, and you can pull it down, you can add to it, you can print it out, whatever you want to do with it. Well, one of the last vestiges of paper is, of course, the handwritten anesthesia record that we had so much controversy over, the 1975 record. So back in '92, when I was a service chief here in Iowa City, a residency classmate and I, Jerry Azan, we applied for a grant to establish a test and evaluation facility of the various electronic anesthesia records that were coming out on the market. We had a great idea. We wrote it up extremely well, and it was turned down flat. Okay, not knowing in headquarters, they didn't realize how expensive that this was going to be, is to have electronic anesthesia record. Of course, the VA's electronic medical record was coming along just fine because it was a grassroots organization. And I was out in the stacks right now, and I ran across a book, Information Processing Within the VA Health System, written by Robert Kolodner. And he was one of my people that I knew quite well within the VA as I was working with anesthesia and we were working with record keepers. Okay, so in '98, Pisces was installed in the ORs and ICUs in the San Francisco VA Medical Center, and they started now collecting some very interesting data, transferring from the operating room to the ICU and then for 30 days following. Very powerful database that they were collecting, and it turned out to be absolutely magnificent for saying, these are the veterans that we predict are going to get into trouble. Here are the chief predictors, and if you have a veteran at high risk, then take care of him and let's mitigate the high risk. In 2007, anesthesia record keepers were rolled out to that entire area, the western, mostly California and southern Oregon. And this was really, really great stuff. So in 2010, more areas were rolled out, and one of the reasons I showed you that area map is that each area, area 1, 2, 3, 4, up to 23, that area is going to have the identical electronic anesthesia record. Okay? So now we've got 23 minus 2 different anesthesia record keepers. Okay? Problem. Because they wanted to give some autonomy. So, and are any of you librarians besides Donna? Okay. Well, we have this thing called the Standard Data Dictionary of Medical Terminology. Okay. In New York, we need to have the same thing called as it is in San Francisco. Okay. Now, you're familiar with SNOMED? SNOMED? Okay. SNOMED is the start of a standard medical dictionary. And we're working through the Anesthesia Quality Institute of the American Society of Anesthesiologists, generating a standard data dictionary. The VA has massive amounts of data now, dealing with mostly men, about 90% men, most of them elderly, although we've got a huge amount now of youngsters entering the VA from Iraq and Afghanistan. So now we have a very rich database for data mining, and the VA now has mandatory reporting not only of bad incidents, but close calls. And the close calls database of something that almost happened but didn't quite is now being correlated with the richness of the database, and the VA is going to lead the world in saying, how can we help improve healthcare? We've got 132 hospitals, about 200 clinics, and that's a huge amount of data. So, what's happening in the last few years? Airway management, outside the operating room and outside normal operating hours. Somebody gets into trouble, has to be intubated. Always before, it was the intern. Well, too many deaths resulting from tubes in the esophagus and stuff like that. So the VA said, we are going to train all of the respiratory therapists in intubation techniques and airway management, and they have done that, and the death rate on nights and weekends is plummeting. That resuscitation now is becoming very good at the VA. And then sedation for non-anesthesiologists, which came out last year, a document on the VA, for interventionalists saying these are the qualifications, these are the tickets, these are the privileges you must have in order to sedate patients and take away their ability to protect themselves. And so we're making a fair amount of progress in that. So my career is sunsetting. I become emeritus in 5 weeks. And it's been a great ride. Been super.